Now I would like to invite Professor Pradeep Kumar, who is currently working in prestigious Research and Referral Army Hospital. He's a coveted retina surgeon and has a large base of research. His recent research on injection brolucizumab has been something which has been done in India, and his experience in that field is quite vast. So, over to you, Dr. Pradeep Kumar, sir.
So in the interest of time, I'll be a little faster. And to straight away come to the point that where exactly OCT angiography helps. So this is a case where if you see the OCT on the top left hand corner, it does not tell you much about the changes that are happening at the fovea. You may feel that patient is having 6/9, 6/12 vision. Why so? You may not be able to answer. But the moment you look at the OCT angiography, the capillary dropout areas, you are able to predict. And the second thing is, even in cases like myopic CNVM, traditionally we have talked about the role in age-related macular degeneration PCV. Even in case of myopic CNVM, you are sometimes able to pick up the flow signals on octa and treat them. Coming to the topic today, macular telangiectasia. So this is something very close to my heart. Before I started my retina fellowship in my post-graduation, I was not even exposed to this diagnosis. But trust me, when you start dealing with retina patients in a clinic, maybe half of the patients who can be avoided intravitreal anti-VEGF treatment are patients of macular telangiectasia. Here lies the importance of this diagnosis. So it's a disease which is bilateral, perifoveal, a neurodegenerative and a vascular disease, occurs because of Mueller cell loss, predominantly in the 5th and 7th decade of life, and has a deep capillary plexus affliction. So there are a lot of differentials which I'll discuss with case example. Normal octa has been discussed. Now what we know is the changes in superficial and deep capillary plexus more so temporally, and they are evident with capillary splaying and capillary dropout areas. So these two terms are important to remember. Splaying, that is the vessels will appear to be farther away from each other than they are on a normal OCT angiography, and a capillary dropout area in the temporal zone, in the superficial capillary plexus cut and in the deep capillary plexus cut, you'll see it 360 degree. This I am talking about the early stage. That is how you pick up a mactil on an octa. Now these kind of changes have been very well documented, and in this enlarged image, I again emphasize in the left eye, if you see that the changes are more so 360 degrees, while in the right eye, you are only seeing the changes temporally. So that is the time differential between a early and a late non-proliferative stage of the disease. So I'll be running through my slide. I'll straight away come to the example. This is one of our early non-proliferative stage disease, where you see a small inner retinal empty area on the OCT, and then you see the OCT angiography. In the deep capillary plexus, you see a little splaying of the vessels temporally. You make a diagnosis, you simply observe this patient and do not offer any anti-VEGF, steroid or otherwise treatment. 40 to 45% patients of mactel are diabetics and may be falsely labeled as diabetic macular edemas. So coming to the late non-proliferative stage, you may see such kind of OCT. Again, the patient has come to you for the first time, has 6/12 vision, is diabetic, and you see this image. Your first tendency will be to inject. But if you see this OCT angiography image along, sorry, my slides are running. So if you see this image, straight away you make a diagnosis of mactel and you do not treat this patient further. Now coming to the proliferative stage, when you see in the choriocapillaris layer and the outer retina layer, you are not supposed to see any flow signal. Here in the outer retina and the choriocapillaris segmentation, you are seeing a small vascular signal. So this initiates the proliferative stage of mactel, where a CNVM has occurred, and this is the stage where you will like to inject this particular patient. So we have to remember a clear demarcation between the pre-proliferative and the proliferative stage, and not to treat every empty cyst at macula. And everything which appears bulbous on OCT angiography is not a mactel. This is a case of a minor VRVO. I'll come to few of our published cases. This was a case of central serous chorioretinopathy, where we saw macular telangiectasia in addition to the diagnosis of CSC. Now here you see that there are deep capillary plexus changes bilaterally. I hope you are able to appreciate that there is a splaying of the vessels and the intervessel space is much enlarged compared to a normal FAZ picture that you see. So these are the changes which tell you that this patient has macular telangiectasia in addition to CSC. Now, second case is that of PCV with a MACTEL. So this is an even more confusing picture. So you already had a macular telangiectasia and now you have a PCV in the same case. Why did we call it PCV? Because the choroid showed classical pachychoroid appearance. We have gone ahead and published about macular telangiectasia being associated with pachychoroid also. So here OCTA comes to your rescue to diagnose the disease. A third case in this series was even more confusing, where we saw acute CSC in one eye and a PCV in the other eye with OCTA. With a single click the slides are running. I'm extremely sorry for that. Now here we come to a case of center involving diabetic macular edema. Now you see this kind of OCT angiography image. Please focus on the deep capillary plexus. Now you are again seeing this kind of vascular splaying, but this is 360 degrees. Please focus on the superficial capillary plexus image. Here you do not see any changes, not even temporal changes. Now this is a case of diabetic macular edema. So here lies the difference, the subtle difference between a case of diabetic macular edema and MACTEL if you were not given any other information and you had to diagnose this case based on OCT angiography alone. So in an advanced stage, later on, this case had this appearance. So another case of AOFVD with vis-a-vis MACTEL. Here you see the case may appear to you in the outer retinal section as a proliferative stage of MACTEL, but you do not see any changes in the capillary plexus of SCP or DCP. So here you will not give the diagnosis of MACTEL, but try to address this problem with other multimodality imaging. A fundus autofluorescence in this case will clinch the diagnosis. A simple diagnosis will be a neovascular AMD. In neovascular AMD, you can sometimes see deep capillary plexus changes which are secondary to the CNVM. But the superficial capillary plexus will remain undisturbed. So that is a pointer in differentiating the disease. So it's not only important to diagnose MACTEL, it's extremely important to differentiate it from the more common treatable diseases. We had another case of tractional schisis. Now in this case you see this kind of cyst inside the macula on both sides of the fovea. One may be eager to diagnose as MACTEL as a neurodegenerative disease, but this is a tractional schisis, very much amenable to treatment. If you peel the ERM or ILM in these cases, most of the time the progression halts for 4 to 5 years. And the easiest diagnosis is the CNVM, which has already been discussed. Now coming to wide field OCTA. So wide field OCTA, it has come up recently. We were using OCTA initially only to diagnose foveal diseases, to say the best. But now we have taken it further to diagnose diseases which affect the mid-periphery. With the advent of the DREAM OCT, which has recently been launched, 130 degree of OCT angiography, probably we'll be doing much more based on dye-less angiography in treating these diseases. This was a 3 mm scan and this is how a 9 mm scan looks. Till now we had a 9 mm scan. Very soon you will have a 15 mm scan in this kind of demonstrations. And when you see a patient of non-ischemic CRVO vis-a-vis ST-BRVO, you are able to offer the diagnosis simply based on a non-invasive, non-mydriatic click in your OPD, and you need not put the patient through any kind of angiography. Similarly, you can see cases of proliferative diabetic retinopathy also, as sir had beautifully shown, that if you do segmentation, you are even able to pick up these NVEs most of the time. So this is an evolving method of diagnosis with better software coming in. Very soon we'll be able to pick up all these NVEs without having to resort to fluorescein angiography. Now here was a case of retinal vasculitis threatening the macula. So this retinal vasculitis we had been treating, the disease had died down in the periphery. We were all very happy about our success. But when we saw encroachment of these capillary non-perfusion areas toward the fovea, it suddenly struck a chord, and we decided that our steroids were not doing enough. We went ahead and started the patient on cyclophosphamide pulse. This patient later turned out to be a case of Behçet's, and we were able to salvage the vision of this patient. So he has lost certain amount of field, continues to be on immunosuppression. So this kind of information, when you do not have a firm belief that why do a angiography in this patient, let me just do a OPD procedure, 1 minute click, and you have a diagnosis in front of you, and it gives you a treatment option. Thank you so much.
Anyone from the audience want to ask, or if then I'll go for the question. Okay, so Dr. Pradeep, you have beautifully highlighted the role of the upcoming advances in wide field OCT angiography system. But since Dr. Vinod sir had also mentioned that if we have to look at the microaneurysms in the at the macula, we consider a 3 mm scan rather than having a 6 mm scan because the resolution falls down significantly. So although we'll be able to capture a larger area, that is good, but if we want to see predominant peripheral lesion, that may not always be a neovascularization, but could be even the microaneurysms which could be there. So definitely we are going to miss them. What is your take on that?
Okay, so whenever we are going for a wider field of capture, the narrow field of capture facility still exists in this machine. So you are not perforce having to take a 130-degree scan in each and every patient. It's based on an external mirror that external lens that they are adding to the machine. You remove it, you get a beautiful 9 mm scan on a routine, or a 3 mm scan if you go on higher resolution capture. Still you are able to pick up those microaneurysms. So I agree that the wider the field, the lesser will be the resolution. But yes, both the facilities will be available in these future machines also to go for foveal captures alone.
I think one thing what is different in Octa is, for example, you are taking a 3 mm into 3 mm scan. So the machine's capacity of the number of B scans per second is 1 lakh per second. So even for 12 into 12 mm Octa, it is going to take only 1 lakh scans per second only.
Correct.
So the number of scans remain the same and the area becomes much wider. So that's why the resolution markedly falls down. So that is the starking difference between, say, you can say FFA and Octa. So that is probably what most of the companies are working now, how to increase the scan limit and how to keep up the resolution when we go to the wider field of Octa.
Absolutely.
Okay, so now we have our chief instructor. Ankur Singh is currently Associate Professor at UCMS, University College of Medical Sciences, and GTB Hospital, New Delhi. And incidentally, me and Bhuvan were faculty at some point of time at that particular institute. So, Ankur, all yours.
Thank you, sir, for this warm welcome and introduction. So with this last topic of the day, I'm going to digress into the field of ICG and FFA. This field has always been dominated by ICG and FFA, and OCT has been a very questionable role. So let's dive into this field of posterior uveitis with the aid of Octa. So as we know, ICG and FFA versus Octa, how far we have reached in posterior uveitis. So dual FFA and ICG have been a gold standard in the diagnosis and management of posterior uveitis. Dual FA and ICG gives a global information about the structural alteration as in the central as well as peripheral fundus. As Dr. Vinod sir has already mentioned, it's a dynamic invasive test. It shows leak. It works okay in cases of mild vitritis. There is a global consensus for the nomenclature, and it has been there for 20 years. On the other side, we have OCT angiography, which is a nascent, fast, dye-free, non-invasive technique to visualize and assess choroidal and retinal vasculature's abnormality. So the details, how does it work, has already been discussed beautifully by Dr. Devesh. I will skip that. So now I come to OCTA and white dot syndrome. In acute posterior multifocal placoid pigment epitheliopathy, you see these as creamy white lesions, which on OCT shows focal loss of RP seen as clumping with the loss of photoreceptor layers as seen over here. And look at these fuzzy margins. When you do an FFA in these patients, you tend to see those hyperfluorescent area. And then later on, the staining of these placoid lesions as seen on FFA. You do an ICG in this patient, they are hyperfluorescent. And in the late phase, you see a subtle, hyperfluorescence in these patients. And these same patients shows exactly the same place, the choroidal neuron perfusion area. So what is the benefit of seeing this with OCT angio? Because this should be there in all white syndrome. No. So in multiple evanescent white dot syndrome, we don't see these flow void areas. You see this is a choriocapillary slab of this patient, and you don't see any flow void areas. But look at the ICG of this patient, you see these multiple hyperfluorescent spot which are there in the late phase. So what do you understand by that? Does this disease includes capillaries or not? Yes, it does. So what is the problem in this patient? The problem is that OCT angio was not able to identify the flow circulation in the end capillary vessels. So this drawback of the OCT angio can help us to differentiate multiple evanescent white dot syndrome for other white dot syndrome. So this was an example where the drawback was used to differentiate between the different pathologies. Now again, when a patient comes to us with another white dot syndrome and he has a decrease of vision, you do an OCT angio, you beautifully sees the CNVM as a cause of decreased vision in this patient. And one of this example is punctate inner retinal choroidopathy. And when you see these abnormal vessels in all the layers, and you see this flow which is digressing from the superior to all the layers in the retina, you're probably looking at a RAP lesion. You see this is a RAP lesion, and this is a patient of tubercular serpiginous choroiditis with an RAP lesions. So OCT can also be used to beautifully evaluate granulomatous uveitis like VKH, where we see these deep lesions which are of variable size with neurosensory detachment. This is the neurosensory detachment seen on the OCT. You do an FFA in this patient, they shows punctate hyperfluorescence. Then later on, these hyperfluorescent area are replaced by hyperfluorescent leakage of the dye, as you can see over here. And you do an ICG in this patient, you see multiple focal granulomas as flow void area, the hyperfluorescent areas. And these hyperfluorescent areas correlate 94% with the flow void areas that we see on OCT angio. And what is the benefit of seeing this flow void area? These flow void areas on treatment tend to disappear, and this tells us that the patient has responded well to the treatment. Now, OCT angio in infectious uveitis. So as we all know, infectious uveitis in like toxoplasma retinochoroiditis, you have a whitish lesion as seen on the fundus over here, involvement of the retina as well as the choroid. And you do an OCT angio in this patient, you see these flow void areas in all superficial, intermediate, as deep capillary plexus as well as in choriocapillaries, telling you that this is just not a retinal pathology, this is also a choroidal pathology. At the same time, you can see these satellite lesions that has been described in toxoplasmic retinochoroiditis. You look at a patient who is a toxoplasmic scar, you see a leak, is it active or not, do an OCT angio and you will see an abnormal bunch of vessel that can help you identify that this is an abnormal vessel that has leaked on FA. So as has already been discussed, how do you see retinal vasculitis? So we always say that OCT angio doesn't shows any leak. So how do we use it? So we know that FFA by its benefit shows leakage, but that's leakage except in optos. In fact, in the conventional FA can work against it, because in this montage view, if you create a montage view, you don't take the scans at the same moment. So you tend to miss those CNP areas. So you do an octa, a wild field octa in this patient, and you can beautifully identify those CNP areas. At the same time, decrease in the vessel density in the foveal region, you can correlate the activity. So if there is a decrease in the FD300, then this means the lesion is active, and this has been very much documented in Patch's disease. Disease entities which were only disease entity which was only in the domain of ultra wild field FFA has now been very well depicted with the using of wild field octa, such as an IRWAN, which is an idiopathic retinal vasculitis, aneurysm, and neuroretinitis. So, one of the most important topic for Indian subcontinent is tubercular choroiditis and serpiginous choroiditis. So, how do you see these lesions of serpiginous choroiditis on octa? So, on octa, you see those fuzzy margins of an active lesion as a flawoid areas, and with the treatment, these flawoid areas tends to develop or they unmask the deeper choroidal vessels. So when you see these deeper choroidal vessels in a serpiginous choroiditis, probably the lesion is healed. At the same time, initially you don't see any flow, but later on the flow will not come because the lesion has healed. Rather, there will be thinning. So always correlate the structural OCT and fast OCT as well as the OCT angio. So always remember that although octa is not able to detect the leakage, but it can detect vessel density, which is suggestive of active vasculitis. Decreased flow in DCP, deep capillary plexus, as mentioned by Dr. Vinod, can be promising imaging biomarker to assess disease severity in birdshot retinochoroidopathy. In granulomatous uveitis, octa has a 94 to 95% agreement with the granulomas that are seen on ICG. Flow deficit depiction, especially in the deeper retina and choroid, may just be a necrotic inner retina. So, if you see an flawoid area, just don't think this is a true flawoid area. Look at the structural OCT. It just could be a scar. A scar will not have a flow. So, if you look at the flow, you find that this is a flawoid area. Look at the structural OCT. It just might be a scar. So, the interpretation of various pathology on this modality is still evolving. So, what in the end I would just like to say is that OCT is not an alternative for ICG and FFA and uveitis, but a respectable adjuvant. So, as like with any new investigations, OCT requires standardization. Keep limitations of octa in mind. Know that it doesn't detect blood flow in vessels which are very small. Inflammation does not detect blood flow. So, keep that in mind while interpreting pathologies in octa. Thank you.
Excellent presentation, Ankur, and I'll just like to emphasize one fact that where one finds a very good usage of OCT angiography is in a burnt out choroiditis disease where you have a lot of atrophy. When you try to do a FA or ICGA, you have leak almost everywhere. You're not able to see your flawoid areas, but on a OCTA, since you do not have a overlap hyperfluorescence like FA, you are able to appreciate these flawoid areas of choroid much better and follow these patients with the treatment. Any comments, Ankur, on this?
I think as I have mentioned before, that an FFA has the benefit that it can show leakage, but this is the benefit which act against it. So as Dr. Vinod has mentioned, that if you have a wide field of FFA, then it's a beauty. You can just in one click get a CNP areas which are very well seen. But then if you do an conventional FA, you can't take scan of all the site at the same time, and you cannot tell that this place is going to have a CNP area. So do an octa in this patient. Even if you are not taking it at the right time, it's just a scan, do it, and you can easily pick those CNP areas. So this will tell you about ways the retina is burnt out, and it will help us you to understand that whether is your treatment doing any benefit to the patient, or you need to step up the treatment.